everybody. It's nice to see you again after a long time. I know, I haven't been here for a long time. Now, we're going to start the lower extremity. We have been going over the lower back and sacroiliac joint, which is the joint in the buttocks area. Today, we're going to cover the hip joint, the actual hip joint. That's very important, and it takes all the pressure of our body. And is usually people get arthritis on that joint in later age. And people that are overweight, they have problems that they're born with, like some malalignment on the hip. They are the ones that they usually get problems on that very big, stable joint of body that we're really dependent on the stability of this joint, and is also mobile because it's a ball and socket joint, just like this, moves everywhere. So I'm going to show you the couple of pictures. I'm going to show you the problems that can happen in the hip. This is the hip joint that I'm going to show you. The healthy hip joint right here in this side, and you see the hip joint that got arthritis, bone on bone, and the bone started wearing and tearing in the other side. So if we have a hip problem that advanced, doctor most likely gives some physical therapy, but sometimes the hip gets stuck because it's very stable, it's very inside that socket, and if we have that bone erosion around it, it's gonna stuck, and we're gonna have a very, very bad lack of range of motion that the doctor finally may recommend the surgery, which is the hip replacement. That's the best surgery on the hip that can happen usually. I'm gonna show you the picture of the hip replacement right here, before and after hip replacement. As you can see, the area of the bone erosion is totally removed, and they put the prosthesis in the bone. So you're gonna be basically iron on iron. So I'm gonna tell my patients that you're not like Iron Man. So there's no joint existed, no cartilage that's damaged existed, or any bone, bony, how do you call it, like erosion existed anymore. You are bone on bone, like a robot. And you're good to go. You can basically take all of your body weight on that artificial, totally artificial joint. As you can see, the full replacement is the ball and the socket. They both replaced with the metal, so you're metal on metal. That's usually very safe surgery. It's very big actually. You can get some incision from outside. You can get incision from front, and you can get incision from the back. They used to do the incisions in the back, which is a little bit harder because they have to dislocate your hip to be able to put the prosthesis in, and then put the hip back in place. When they dislocate the hip, they have to overstretch and damage some tissues around the joint. And then if that tissue length gets a little bit longer, or get loose, this structure get loose, you're gonna have a loose joint. So for months after surgery, you have to follow some precautions, especially for people that have posterior stitches. They have to make sure they don't go more than 90 degrees. They don't bring the leg forward more than 90, not knee to chest. Make sure they don't cross over the legs, because it's gonna make that artificial hip joint to dislocate. And that's going to be a problem. So you might have to end up to the surgery room again to fix it. So you do have to really follow the precautions that your doctor give you if you have a hip replacement for probably months, whatever your doctor tells. And just going to show you a couple of general exercises for the hip to strengthen. And if you have a hip replacement, I'm going to show you a couple of exercises for after hip replacement that they are safe, and you can do it also. But hip arthritis is not the only thing that they can get. Some people, like younger people, they can have some malalignment from the birth that they never know even that they have it. So how you can check that on yourself, I'm going to show you a quick, it's actually a Craig test. It's a very big test in physical therapy, but you can kind of do it yourself too, to self-assess if you have a malalignment also. One big hint that you can make sure you have it in your mind, if you have been walking in toe, if your toes are in when you walk, always have been like that, you most likely have some deformity coming from your hip. But sometimes it's not the case, sometimes from the ankle or from the knee, but most likely it could be from the hip, the origin of the problem. So you might have something we call the anteversion of the femur, which I'm going to show you the test and how to check that. And as a kid, some kids, they have a really hard time, which I was one of these kids. They have really hard time from the childhood to sit crisscross. These kids, they usually have the lack of external rotation of the hip, so we call it the femur anteversion. So they have the same deformity. If it's really severe, these kids can walk in toe also. If not, they only have problems with the crisscross sitting, and they like to sit like W, which that was my favorite way of sitting as a kid, and it's not a good way. That's one way for you to recognize your kid might have a malalignment on the hip if they really into sit on the W versus the crisscross. Okay, so now I'm going to show you a quick test how to self-assess yourself to make sure that you have this femur anteversion or not. You're going to lay on your stomach, bring your legs up. You can do one-on-one or both. I like to do it one-on-one. So what you do, you try to stabilize your hip and then let your knee go outside. When your knee goes outside, your hip actually turns inside. So hip internally rotates. So what you do, you're measuring internal rotation, how much internal rotation you have. Now you can go back and do external rotation. Look at me, how limited I am when my knee is going in, which means my hip is going external rotation. So you see how limited I am? So this kind of people, they have anteversion of femur. So they are more prone later on to getting early arthritis because of the deformity or malalignment they have. So this one, the left side you see, it's even more. It goes really internally rotates. Too much, okay? And then this one not going externally rotate that much. It stops. So that way you can really diagnose people with anteversion. Some people can have retroversion, so it's not that common, especially for the female kids. They really have more of an anteversion or internal rotation of the femur than retroversion or external rotation of the femur, but they might. So some people can have, which I cannot show you because I don't have enough, some people can have more external rotation and less internal rotation. That's called retroversion of femur. Both of them causing problems. People with retroversion usually walk out toe, which is not too bad in terms of what we're going to talk about later, in terms of the problems that can cause, but still not proper alignment. You're supposed to have like 45 degrees or a little bit more internal rotation and 45 degrees or a little bit more external rotation, equal, both sides. So then we can recognize as a normal hip alignment. So I'm going to show you a little picture here. It's talking about, that's showing you actually how that can cause into. You see that showing person's shoes right here and shows the alignment of the femur. You see the angle right there. It even shows the angle to you. It says 35 degrees of the angle between the head of femur. We're looking at the person from the top to bottom, and you see how this is like a normal 15 degrees, and this is how wide the angle is. And if it really gets severe, it's like a picture down there, it can cause a little bit of in-toeing. You see the person walks in the in-toe. I'm going to show you right here. Maybe it's easier for you to absorb this way. For example, my hip that's internally rotated more than externally rotated, so I have a lot of internal rotation, I don't have enough external rotation. I'm very prone to walk in toe, which the good thing is it wasn't that severe, so it didn't cause me to walk in toe. But some kids that you see, they walk in toe a lot. You have to really get their hip checked from the childhood to make sure you can fix that deformity as much as possible. Sometimes it's a bony, so it's not fully fixable, but most of the time if they are a little kid, they can be fixable. They can be not that bad. So people that have anteversion, especially anteversion, they have a lot of weakness on the external rotators, which is the glutes, because the glutes muscle that are external rotators and the piriformis muscle that is mostly external rotator, these are getting overstretched all the time because the person doesn't want to do external rotation, always does internal rotation, always overstretch these poor guys. So what we're gonna do, it's the same thing that we talked about in the sacroiliac and the back section. So it's very important to strengthen the glutes. So the very, very easy external rotation strengthening is what? It's gonna be our clamshell, our friend, right? That's how we can strengthen that external rotators to make sure we can fix that as much as possible, fix that anteversion of femur, the deformity. So that's the exercise that people, probably like me, they have to do a lot, like the external rotation of the hip. Another thing they can do, of course, they can add the band to it. We already talked about, but I can show you again. We can add the elastic band, okay? And if you want to make it more effective in terms of alignment, what you can do, you can grab a pillow, which I'm going to show you here. You can put that pillow underneath your feet, and that's going to give you a better alignment for that exercise, okay? That's one of the best and easiest exercises you can do to strengthen your external rotators to help with that femur deformity. Another exercise, another way of exercising that could be with the weight. If you have a weight at home, I have a weight that I decreased it so I can show you easier. So it's some kind of weight cups you can purchase. I got mine from Amazon. Not too expensive actually. So what you can do, you can put it on the, sometimes it can be put on the ankle, but in this case we're going to put it up higher because this is going to be a better alignment for external rotators. So what we can do, I put it here and I go up against the weight. If I put it on the ankle, as you can see, it's not going to be as effective for that hip external rotator. So you're going to do it this way. Got it? So another exercise, I can have it on to show you another one. This is going to be our favorite doggy pee position, right? Fire hydrant. So what we're going to do, we're going to do this. That's another external rotation, really good one, right? It even gives you a better alignment to do that. Very important one. Another one we can do is we can actually do a lot of external rotation with encouraging, if it's a kid, to tighten up the buttocks or pinch the butt when they walk. So if they pinch the butt, they automatically externally rotate the hip a little bit and the outs to the foot and correct the whole alignment on the lower extremities. Important. So pinching the buttocks, trying to strengthen the glutes, and sometimes we have to do some stretches also. These are very good stretches just to sit crisscross. That's it. As easy as this. Sit crisscross for as long as they can tolerate. Usually the kids with that problems, they cannot tolerate too much crisscross. They probably end up starting like this, and they hurt a lot around here. But that's okay. Let them just do as tolerated and encourage them. Make sure they are pain-free, because as a kid, if they are in pain, they're not gonna do it. So make sure you go with your hands slightly, try to put your body weight on, encourage them to stay straight and try to push it. Probably after a couple of weeks, they're gonna be able to get to that position if they are not so severe. And if they can go even more, you can go to the yoga pose and start getting to the next level and doing that, which I'm not that good at this because I have had this deformity for a long time, of course. So these are good stretches you can do. Always encourage them to strengthen the glute maximus too, which doesn't do only external rotation, it does extension also. So the extension part of it, I can show you with this also. So the extension part of it is easy. You can either do it with this or with the stand underneath your other foot and go up against, tighten up the belly and hold it. I've shown you in different sections because strengthening the glutes is also good for the back pain and sacroiliac issue also, but it's very important and very vital for the hip joint to do this daily if you have a deformity like anteversion, which is very common, especially in the female kids, and we go from there. So that was for the deformity, but I'm going to show you a couple of general stretches too, because some people that they have this deformity, they also have the tilt of the pelvis, which we already talked about the tilt. They already might have anterior pelvic tilt. People with anterior pelvic tilt, they'll have a lot of tightness in the hip flexor. So I'm going to show you a couple of the hip flexor stretches. Very easy. So the first one is going to be the lunges. We're all familiar with the lunges, right? The best way of doing the lunge is trying to do this way and trying to pelvic your tilt also. So don't go like this, because this is not going to do enough. So you're going to try to correct the pelvis tilt while you're stretching your hip flexor. So instead of doing this, we are correcting the pelvis tilt and doing that. And hold it for 30 seconds and relax. And another way of doing the hip stretch is you're going to be on one leg and trying to bring yourself forward. Again, try to tilt your pelvis in a good tilt. Hold it there. You're going to feel a good stretch in the hip flexor. Usually the hip flexors are very, very tight also for a lot of people with the hip deformities, and also the lower back problem and the sacroiliac problem all. But this is going to be one of the vital stretches, the hip flexor stretch, that you can do. Along with that, so you can always strengthen a lot of other muscles, or stretch a lot of other muscles, the lower and higher. Higher than that is going to be a must, but mostly the muscles that need to be stretched on people with the hip deformities as a young adults without any specific arthritis or anything would be these two, the hip flexors, and if you have anteversion, definitely you gotta stretch that internal rotators, because your internal rotators are always tight, and you're gonna strengthen your external rotators. So this was for the hip deformity, and I'm gonna cover probably in the next video the arthritis of the hip and something you can do in arthritis on the hip. So the other thing that for people that they have the deformity they can do, sometimes they get impinged. The impingement of the hip is going to be common also. We have a labrum which is covering the bottom of the socket, so that cartilage. If this cartilage gets tear or if it's impinged, again this kind of deformity can be happening, that's impinging. If you see the red area, they are impinged, but they are not arthritis yet. So if that's the case, then again you have to try to stretch the hip, so you could try to distract the hip. Remember we talked about distraction? We told you on the sacroiliac, so you can do hip distraction with something like that. You can add a band here to the leg of the table, but it has to be a sturdy table. I'm just showing you as an example, okay? It's not really a sturdy table that I'm using right now. So what I'm gonna do, I'm gonna pull myself back and let my legs stretch really good. Okay? I'm distracting, so I'm letting that hip joint to distract a little bit and get rid of the impingement that's happening there. Okay? Another way of doing that is we're going to distract in different directions. As a button socket joint, when it moves and rotates, as you can see, when I move like forward, my head of the femur goes backward. You see that? Slides back. And when I go this way, the head of femur slides the opposite way. If you can see that the easy sample, you can see why we have to glide that joint also. Sometimes the gliding is a problem. It's not the distraction that's helping us. It's the gliding that's stuck and the range of motion stuck. So how we can help with the gliding? That can happen with the band also. You can use the band. I find one of these techniques a little bit easier than the others, which is going to be this one. I'm gonna let this go. I'm gonna go to the quadruped position, if you can see. And I'm trying to let that band pull against my movement. So basically the band's trying to pull my hip backwards and glide it backwards. If it glides backward, that really helps me to get rid of impingement in the front of the hip. Some people feel a lot of impingement and a lot of tightness in the front of the hip is not muscular because they already stretched the hip flexor muscle, is not helping enough. So we go to the next level, we try to distract the joint first, as I showed you, and we try to glide it backwards also, which this is going to be a self-gliding motion. You can do posterior glide, very important. Some people have their hip stuck inside or outside. What they can do, they can go this way and let that band pull this joint out of the socket towards the outside. If the joint impinged inside, they can get rid of the impingement inside. Usually, hip has a tendency to get impinged inside and in the front. Not much in the back, not much outside, but sometimes it happens. Sometimes people can get impingement in the outside, especially people that have bursitis in the trochanteric area. They can have very tight IT band, which we're going to talk about later, the muscle that attaches here. It can get tight and impinge like the structures on the outside. So these kind of people, they might have a different stretches that's necessary for them, which we might talk about it in the maybe knee section, because the IT band is usually between the hip and knee, but I like to cover it in the knee section because IT band is usually more for the people that they also have a knee issue, because it's a double joint muscle. It goes from here and to the knee. Usually for the athletes, runners, they get that, but we're going to cover it probably in the knee section. For the hip section, I think the most important thing is the impingement. It can cause, if it's impingements too much for a long time, the labrum, which remember we talked about labrum in the shoulder. Labrum is the cartilage that covers in the bottom of the joint. That cartilage unfortunately can get tear. And when the cartilage damages and get tears, one-time things that God given to us, the cartilage, and if it tears, usually doesn't get repaired by itself because it doesn't have enough blood flow. We can get PRP injections, try to get cortisone to get rid of extra inflammation, but we most likely cannot repair that cartilage. We have to do the surgery to get rid of the part that's on the way of the movement. But this is not going to give the cartilage back to us. So we really have to take care of our cartilages, because when the cartilage is gone, it's gone. And when the cartilage is finished, what happens? We're going to get bone on bone, and it's going to be arthritis. And then what's the next solution? Hip replacement. So we're going to make sure that we don't get there. Okay? So these kind of exercises that I offered hopefully helps you with the prevention for people with the impingement, people with the deformities. They're trying to prevent their joints from getting arthritis. But later on, if we get arthritis and we have to go through the hip replacement, what's next? So hopefully it's going to come in the next video. Thank you for watching and have a great day.